Good evening, everyone, and welcome to this meeting of our Health and Adult Social Services Scrutiny panel. Today is Tuesday, the 17th of March. I'd just like to start by reminding officers and also members of the panel. The meeting's being held in hybrid form. We have some members and officers joining the meeting online. So online we have Kerry Stevens, who's our Strategic Director of Adult Social Care and Public Health. The meeting is also being live streamed on YouTube. Can I remind members and officers who are online just to be on mute and to use the raise the hand icon if you wish to speak. So I'd like to just start the meeting this evening with some sad news about one of our panel members, Councillor Dr. Aisha Raza, who sadly passed away after a sudden illness at Ealing Hospital on the 15th of February. Aisha was somebody who to many of us was an important friend, but also a very talented colleague. She served on this panel for a number of years, and colleagues around the table will remember that she played a huge role in the Save Our Ealing Hospital campaign. And I just wanted to really record our sincere condolences as a panel to her family, and really to offer it to colleagues around the table, just to share any reflections by way of tributes. I was very fortunate to have the opportunity to share some reflections at full council, but wanted to offer it open to both panel members, but also officer colleagues and partners, if you wanted to share any reflections, because it is a big loss to our panel, but also to the borough as well. So happy to open it, Chris.
Thank you, Councillor Weston. And again, just to add our condolences to all colleagues, family members and friends of Councillor Raza. I had the privilege of knowing her for the last 10 years or so, since I've been in a leadership position here in West London Trust, and have two abiding memories of Councillor Raza. Positive abiding memories of Councillor Raza, not in addition to all the memories I have of her offering appropriate scrutiny of our services. Those two are in my West London Trust role. We have a great service that supports asylum seekers through bringing the community together and providing catering and working with the University of West London. And I attended for a breaking of fast event and was surprised and delighted to see Councillor Raza there, kind of holding court in a way that one would expect from a politician, but also really embedded in the work and celebrating the relationships there, and celebrating the work of our diverse borough. And a second memory was a recent one. Another role that I have is as a trustee in Ealing MENCAP. And we had a fashion show for members of MENCAP, which again had a number of local individuals present. But I have never failed to be impressed by Councillor Raza's enthusiasm for activities like that, and the community, and the energy that she brought to celebrate the good work around health and care in the borough. So just to record from myself and from the trust and from MENCAP our condolences.
Thanks very much, Chris. I'll go to Anna and then Nehar after that.
Thank you, Chair. I just wanted to reflect, we talked about Councillor Raza's passing at our team meeting a couple of days after her death, and the abiding memory is just how human she was. I think she covered a lot of our team members, especially during COVID, but particularly when she was lead member with the inequalities hat on and substance misuse. I think not just that focus on equity, but especially on our more vulnerable residents, and really thinking about how we look after them as residents. But I was here at the last panel and she was asking after my son and looking at kiddie photos, and I think she was always very human first with all of our team, and I think that's the abiding memory that our team shared with us. So thank you.
Thanks very much, Anna. Nehal.
Thank you. We also wanted to share our condolences from the whole NHS family. I remember the last time I saw her was a couple of weeks before the very sad news that was heard about Councillor Raza. But she was crossing the road in front of me as I was turning into the car park, dressed in sparkly clothes for the Greenford Library opening and the event that afternoon. And I walked into that library thinking, I'm not sure I know many people. And first person I saw was Councillor Raza, who just grabbed me and said, right, come on, let's take a photo together. What's going on? And it was just such a lovely memory. And I just wish I'd kept that photo, but it's somewhere in the library, I'm sure, which I will try and get. Thank you.
Track down the photos. Those are precious memories. So Councillor Jammu and then Councillor Mataza.
Thank you, Chair, for giving me this opportunity. I've known Councillor Raza since about 2016, 17, and she was already a councillor at that time. I first became a councillor in 2018. And we go back a long way. She had a passion for NHS, Save Our NHS, and I've been on many a march with our fellow councillor Aisha Raza. But I'd like to share today's memory with all of you guys. This morning I went to litter picking with the Lager Kenners because they were around the corner from me. Took some drinks for them as well. And the first thing they said to me was, isn't it sad about Councillor Aisha Raza? And there were two groups there. There were people there from Horsenden Farm, and then there were the Lager Kenners there as well, our voluntary groups. They spoke so highly and of Aisha and the work that she did right throughout the borough. She didn't care who the organisation was or what they were doing. Her main purpose was just to spread the word in the community. And I think that really meant, a lot to her and a lot to me this morning when members of the community, the voluntary sector, actually came up to me. Sorry, I'm still got a lump in my throat from this morning, and came to us, with all their kind words. It's really appreciated. And I also have to say that on Sunday, we broke fast at the Bilal Masjid in Greenford. And the first person I missed when I got there was actually Aisha, because last time round she was there with me. We were sitting next to each other thinking, what shall we eat and what shall we not eat kind of thing. She was such a community person. She, and even the North Greenford Residents Association's meetings, she'll be out there in force. I will also say that at our last retired members group meeting, I'm also chair of Reading Unison Retired Members, for those of you who don't know. And we had a meeting always on the first Thursday. And in my chair's report, I honoured her and everybody at the retired members group, because a few times I got stuck for speaker, and her being a health person, April is always a health month as far as I'm concerned. I mean, every day is a health month, but April more so. And she came and, she held the fort. She wore the right cap at that time, and my members were so proud of the way she delivered. And another time I remember when she was cabinet member for Safer Communities. My members range from 65 to 104, and she arranged a Safer Community team to come down and speak to our group. Absolutely, really heartfelt condolences to her and all her family. I would also like to add another community member who spoke to me. In fact, he was the first person to speak to me about Aisha. He is the one who set up the Grape and Honey Farm just round the corner in North Greenford. And he was the first person to come to me and he says, I've just heard about Aisha. Have you heard? And that's how hurt and gutted the public has been out there. And on a serious note, heartfelt condolences, Councillor Weston, to you as well. I know you two were good friends, and to her family. Thank you
very much, Councillor Jamie. Councillor Mataza.
Thank you. I have known Aisha for the last 4 years when I first got elected as a councillor. And as they say that our funerals reflect how we have spent our life. And I was so amazed when people gathered for candle vigil or her funeral at Harrow Mosque and the condolence book signing. It was a long, long queue and people coming from all across the London. Even the Mayor of London attended her funeral. She was very pleasant and very sympathetic and considerate person. She was compassionate about inequalities in health, and she has left all the good memories. Actually, I used to, and all the Muslim councillors used to give iftar dinner every Ramadan. So it was her suggestion that shall we do this year as collective. So although she was not there, but we did it as collective one in her memory. May her soul rest in peace. Thank you.
Thanks, Councillor Mataza. So I think we'll move to the next item, but thank you everyone for those wonderful tributes. So apologies for absence. I've received the following apologies, just Councillor Tai this evening. We have Councillor Newstep attending. We also have Neha as our local director for Ealing NHS. VJ is here again as the Borough Medical Director. Chris Hilton as our Chief Operating Officer, and we also have a number of presenters who I'll introduce at the appropriate point. I should point out that this evening is Kerry Stevens' last meeting, and I just wanted to sincerely thank Kerry for all of the support that he's shown this panel. I think, Kerry, you've really highlighted how a director and an officer should interact with a scrutiny panel in the way that you've approached your work with openness, but also with a good sense of humour as well, which is always appreciated. So just wanted to say congratulations on your retirement, and thank you very much for everything you've done for this panel. So I'll move on to urgent matters. I have no urgent matters this evening. And then we move to our usual declarations of interest. I'll get us going. I'm employed by the Nursing and Midwifery Council. Councillor Mataza.
I am a GP providing services in Ealing.
Councillor Conti.
I'm a GP in Hounslow.
Any other declarations of interest from panel members? No, in which case we can move on. Matters to be considered in private. There are no matters to be considered in private this evening. The minutes. Can I confirm that panel members are content with the minutes of the previous meeting on the 29th of January? Agreed. Thank you very much. Which moves us on to the next item, item 6, which is Ealing Adult Mental Health Services. And Chris, I will pass directly on to you if that's okay, and I'll allow you to introduce colleagues as well.
Thank you very much, and thank you for the invitation to respond to the interest of the panel in mental health services in Ealing. My role is as the Chief Operating Officer and as a psychiatrist in West London Trust, but as with a previous recent panel, I've brought along colleagues who are more directly responsible for the clinical leadership and operational leadership in Ealing. I have apologies from Dr. Julia Renton, who is holidaying. She is the borough director for our Ealing mental health services, but is ably assisted by Sharon Thompson as associate director, who's with us this evening, and Dr. Raquin Cherian is a consultant psychiatrist and the clinical lead for our community mental health services for adults here in Ealing. What we have attached to the pack is a focus on adult services, as agreed with you, Chair, and we had sought to do a couple of things with this pack. One is to try and describe the scope of adult mental health services which Ealing residents have access to through West London Trust's services. But we also recognise that there are a number of both national and local challenges in respect of mental health provision. And we wanted to address a couple of those. So we've included some data in relation to acute mental health demand and presentations here at Ealing Hospital and across the North West London area, including the work we do in partnership with our neighbours in CNWL. And we've also thought that the panel may have some interest in the request for all mental health services to respond to individuals who don't engage in mental health care in response to the shocking incident a couple of years ago up in Nottinghamshire. So I will stop talking and invite my colleagues to perhaps draw some highlights from the pack. I will share my screen in a second for those watching, but we'll try not to spend too long doing that because I'm sure we'll have questions.
Hi there, good evening everyone. As Chris said, my name's Sharon. I'm the Ealing Associate Director covering the mental health services. I echo Chris's thanks for the invite here. We really welcome the opportunity to connect, and just to add sincere condolences on the loss of someone who sounds like she was a really good friend to people as well as a colleague. So yeah, mental health services, a big, gnarly, clunky. So I'm going to attempt to take you through a sort of canter of our services, be quite open about some of the challenges and some of the work we're doing to redress some of those challenges. Moving on to slide 1, we intentionally put that in there because it's the core mental health funding across North West London. And I think it's just stark, and I just want to pause it there. You can see the difference in the funding per weighted population for our core mental health teams. And we will get into the detail of some of the work we're doing to level that up. Moving on, obviously we have a high referral acceptance rate because we were one of the first trusts to do community mental health transformation, to try and break down the barriers between what was primary care and secondary care. We've had a lot of success in that area, but still work to do, as I'm sure people practicing as GPs are mindful of. And obviously we've included in there the staff per 100 patients, which I think is really quite stark to see that, but we have hopes where there's work in place to level up some of that workforce information. Moving on, so that's our organisational chart for Ealing Mental Health Services. It's quite small there, so I'm sure you've had a look, but that's the array of services that are offered within Ealing as part of West London Trust. We're really quite excited about the next slide and the borough-wide project and the plan to roll out trauma-informed approaches. And where we're at with that, trauma-informed approaches is not new, and a lot of our staff are actually already, working in a very trauma-informed way. But we want this to be a consistent language across Ealing, and that there are plans to roll this out more widely. And where we're at the minute, we've done 4 launch events so that all of our staff employed within Ealing services are very familiar, and we start to embed the culture of trauma-informed approach and the language that's used with that. And we've got 2 more launch events planned, I think, for March and April. Each team has identified at least 2 trauma-informed champions from their team, and they've all been trained to deliver these. So the next part of that process is for them to roll that out across their teams. I have a couple of the stabilisation manuals with me, and I'm happy for people to have a look. But there are there's 10 workbooks in that. You might read it and think, oh, these are quite simple things, but when you actually start to role play some of the exercises you would be doing with the residents of Ealing, it's not that simple actually. So that training has really focused on that live role play amongst staff. We've then done an overview of some of the key teams. Obviously, people will be familiar with liaison psychiatry. So our team's based within the Ealing Acute Hospital. We're going to touch on some of the demand, which is ever increasing into the emergency departments, and obviously our joint work with the acute trusts, the housing pathways, drug and alcohol pathways, etc. Need to be very tight in order to support people through the emergency department, which all of us would agree is not the right place for someone with mental health needs once their physical health needs have been addressed. And we move on to the role of CAT. We call it CAT. It's the Crisis Assessment and Home Treatment Team. Again, most people will be familiar, multidisciplinary team with the aim of supporting individuals where possible and where clinically safe to avoid an inpatient admission, because we really recognise that inpatient wards, they're working with some of the most acute unwell people. So if there's a way to support individuals to stay at home with family, and those teams are doing 2-3 visits a day in some cases, depending on how unwell people are. There is a degree of the person wanting to engage in that service, and we're really, really mindful of people who struggle to engage with teams for different reasons. So we really work hard to try and do that engagement piece, whatever way that looks. Our crisis team normally are working with between 60 and 90 residents of Ealing at any one time, but when you think that sort of equates to a morning shift, 50 home visits at least, and then you have to do the same in the afternoon. It's a 24/7 service, and they do operate access out of the core hours, if you like, and their core hours are sort of 10 p.m. Safe Space, this is really quite exciting. So from the 1st of April, Hestia is going to be the organisation running the Safe Space. So we're in a transition phase with Mind, who were previously running that. They were based at Matlock Road, and after a couple of visits we thought, is this the easiest place for residents to get to? Is it familiar? So we've taken the decision for Safe Space Hestia to move in beside the crisis team, and that's when we consult with some residents, they say, oh, it's too clinical, it's too hospital, I have memories there. But I think when you consider that someone in the emergency department receiving support from liaison psychiatry, Hestia could go over and support them and see them in that area and sort of tell them about the service. Equally, Safe Space will be co-located with the crisis team, so it's another offer of support for those individuals, particularly I think for people who are quite isolated and lonely and really struggle with mental health symptoms, particularly in the evening. They'll operate from 2 p.m. until 10 p.m. We're really keen on it being a drop-in service. But I met them this morning just to get the estate stuff up and running, so they will be in living with us from the 1st of April. They're really excited. They've done it in that way with other trusts, so they're really looking forward to it. NHS Talking Therapies, it's a massive service in Ealing, employing about 100 substantive staff, and they have 20 trainees. And there's some of the figures in there, I think, which shows just how busy that service is. And they offer CBT, post-traumatic stress disorder type treatments. They have a range of therapies and interventions. Community rehab service, I keep talking about it as a new service. It's not new anymore. But I think we've been described as an exemplar in this, the development of our community rehab services across Northwest London, so that standard rehab approach is evidence across all of the boroughs within Northwest London. They've been really focusing in on, as Chris referenced, we've got high demand for inpatient beds. We know there are residents who really struggle to kind of cope at home. So they've been focusing in on people who've had 2 or more admissions in the last 12 months to put a more multidisciplinary team wrap around a level of support. And that we're seeing some early successes with that, but time will tell. And then we have the SEN team. So we use lots of acronyms, apologies. That's our complex emotional needs team. They're working with probably some of the more, I say complex, it's not the right word. I think the greater prevalence of needs, and they really struggle with that emotional regulation piece. And they're really working on that dialectic behavioural therapy approach and intervention. They hold a small caseload because, again, it's a high intensity service. And they're tri-borough. They operate across Ealing, Hounslow, and Hammersmith and Fulham. Early intervention and psychosis, again, people will be familiar. That's for young people now. It's age 14 upwards. Used to have an age limit of 65, but that's beyond. They have very tight key performance indicators, seeing people within 2 weeks, completing that assessment and accepting them within 12 weeks. And it's the young people. It's trying to support young people back into education, employment, stable housing, to support them with their family relationships, which is often quite tricky at those younger ages. Chris has mentioned, obviously, that very tragic case up in Nottingham, the Valdo Calcane case, and we've all been tasked with what's your approach to try and make sure those who find it difficult to engage with services are proactively worked with. And what we've done in response to that is introduced something called a flagging system. The criteria is described in the pack. Our electronic patient record systems now are able to record it, and we're able to pull reports out. And what we've done for those with a complex flag, we've set the frequency of contact as twice per month, and those with an acute flag. And in layman's terms, it's someone who's out there in the community, they're really struggling with symptoms and risk, and the level of frequency needs to be much, much more. We've put in a joint bid with CNWL actually to try and resource that assertive outreach staffing group, and we're really hopeful that we'll be able to weight Ealing using our weighted population figures so that we can try and level up a bit more in terms of resource and staffing. You've got the visual of the flagging and what acute means, what acute other means, so I won't labour that point. I think it's fairly intuitive and self-explanatory. And then there's a slide in there showing our flagging dashboard. It's just a screenshot. It's not our total caseload. I think across Ealing we're working with at least 10,000 residents under the various mental health services. But that's the system that managers need to use to make sure we're not losing anybody. And that we're, for complex people, that we're seeing them twice a month, etc. And that's minimum. And then the flagging performance, that's some of the matrices that we use within our governance meetings within the Trust. So now we come to the urgent and emergency care challenges. So we're all really well versed on some of the high demand for inpatient services at the minute, and we are seeing really much more unwell patients, and our length of stay in Ealing is something that we need to continue to focus on and address. In Ealing, we've decided we previously had a service manager who was responsible for the crisis team and a different one who was responsible for liaison psychiatry. So we're going to pilot something quite different from the 7th of April. We want the same service manager to hold the responsibility for both of those services. Because what happens is, we all know when services are under pressure, they operate in silo. And we want that escalation point to be the same person so that there's a trusted decision making across both services. And we were seeing in mind the safe space, really low footfall of the people that we thought would use the service. So that's why we've pulled Hestia in to sit alongside us as our partners in the same building. So we're going to track that. Are the right people accessing safe space? We've referenced there the lower staffing ratio in Ealing ED due to historic funding, but the good news is we have a new consultant starting with us actually yesterday, and we've got 2 Band 7s coming in to support an ED LPS joint triage. So at the minute, just for your information, LPS liaison psychiatry sit up on the 9th floor. The ED's obviously down 9 floors. So we've identified a room in the emergency department where we'll do that sort of within 1 hour screening alongside physical health colleagues. And to be honest, the team are really passionate that physical health needs are also equally considered at that point. Our data is also telling us that Ealing does import people at times, and we see people occupying our beds coming from out of area, and that in itself is a complicated thing to work through. We also have a ramp team, which is absolutely fantastic, but when people find out you've got a ramp team, that homeless population will often move into the borough because the service is well known and well connected with Street Link and St Mungo's, etc. And as I referenced before, we're really working to reduce our length of stay for some of our longer stay patients. In order to meet that challenge, I think Kerry's on the screen. I think it's fair to say really good joint working. We have a rapid discharge team who are really connected in with our inpatient wards, and there's a bit of information in the pack around our development of step-down provision. So when there's a barrier to someone going home, be it they have no electric, no heating, they can't get in because of a lock, and we haven't identified it until the person's well enough to leave, that we're able to access those step-down beds. So it's a you know, a less restrictive place for that person to settle back into the community. There's some data in there for those who like data around our ED attendances. And I have to say, we look at the sit rep every morning and the heart either sinks or it goes, oh, it's going to be an okay day. But we're seeing a lot of prevalence of ED attendances in Ealing. I think like never before. For those who, liaison psychiatry is new to me since 1st of April last year, and the team report, we're seeing something quite different happen in Ealing. Seeing lots of emails pop up as I'm sitting here, sorry. And then our average time spent in the ED, we are an outlier in Ealing, which is why we're putting in the additional senior resource of a consultant psychiatrist. We're really hopeful that that pilot with ED colleagues at the front door will try to reduce some of those lengths of stay, because we're seeing people come with different social care needs. So we want to make that connection into drug and alcohol housing pathways much tighter and swifter, and that there's joint decision making. Scrolling through the rest of its data, it breaks down that sort of 24-hour, 72-hour, and there's a really well embedded escalation pathway. I would say once people hit that 12-hour in the emergency department, then there's certain things get pulled into place to try and unblock that. Mental health step-down provision, it's really expanded, I think, over the last 2 years, and the team do a great job really at trying to keep that length of stay between that 2 and 6 weeks, because it's, as you know, it's really important to keep that flow and that option available to people. And there's a really tight oversight process for that, and really good partnership work. And I've loads of examples where I've seen West London and local authority work to support people to move back into their own homes or to an appropriate place. So improvement projects, I've mentioned the triage nurses at the front door of the ED. Our mental health clinical assessment service, which is located over at Lakeside Unit, they did a soft launch in December of last year. They now have 6 bed spaces, with the plan to increase that further towards the middle of the year. I mentioned before, we'll have one service manager covering liaison psychiatry and the crisis team. And the idea is that we don't duplicate assessments. So once liaison psychiatry say, this is for crisis team, this is for crisis recovery house, this is for home, or this is for one of the other community teams, there's then not that to and from that we sometimes see in clinical practice, but we've built in a clear escalation process, because there will always be cases that we do need to come together and discuss. Medical resource, and I mentioned the liaison psychiatry individual started this week. And then there's a reference to a focus on standards for out of our psychiatry response, but I'm not cited on the detail, and Chris might want to say more. And I think I've covered the trauma-informed care and stabilisation. We were asked to include something on the right care, right person with Metropolitan Police. We're really, really sad actually that our mental health police liaison officers, Brooke and Mark, I have to mention their names. They're fantastic. They finished up Friday of last week, and we've met with, I think he's an inspector, Sean Lynch, last Friday, and we've got a bit of a 2-hour workshop session with the inspectors for each of the wards, or whatever they call them in the police, to come together and say, right, how are we going to manage warrants? How are we going to manage information sharing requests, those welfare checks, etc., etc. But yeah, that's a support that's going to be missed, and we'll need to develop some really clear pathways and points of contacts going forward. And we've just included the inpatient ED escalation processes, and I think that brings me to an end.
Thank you very much, Sharon. And I guess just to finish from my perspective, I think it's worth acknowledging there are a number of challenges that we are experiencing, in which we're not alone, and we do benchmark well with a number of our peers in respect of our performance. And just to clarify the references to the police changes, there is a change in the police operating model for the Metropolitan Police that they have moved away from having specific mental health officers as part of their new model for neighbourhood policing. So we understand the need for their organisational changes, and we're doing our best to work with them to make sure that we can continue to collaborate. But I'm aware you will want to ask questions, so I'll stop.
Thanks very much, Chris. I have some questions, but I'm looking around for indications first. So I'll go to Councillor Baines, Councillor Conti, and then Alan, was that you as well? Yeah. Councillor Baines.
Thank you for the report. It was a very interesting report to read, I may say. Yeah, just on the Met Police, which I found quite worrying, seeing that you do have police officers that go out for welfare checks. I mean, seeing the position we're in now, going forward, would you be then providing training to NHS and council services to make sure that safety checks are in place? Thank you.
Yes, so when the police implemented their new approach called Right Care, Right Person 2 years ago-ish, they were very keen to ensure that they weren't criminalising individuals or appearing to criminalise individuals in mental health distress. And they worked pan-London with the mental health providers, including ourselves, to where possible, bring about a health response for a health emergency. So that's why we have invested in additional resourcing for our 2-hour response teams to be able to go out and do that for patients that are known to us, and working with the ambulance service. In certain circumstances, the police will still respond where there is an immediate danger to life and limb. And we have an escalation process where we feel that a crime has been committed, or there is a risk of immediate harm that enables us to get a police to cooperate with us in response. But yes, training is part of that, and we're doing that jointly with officers and Pan-London.
Thanks, Councillor Baines. Thanks, Chris. Kerry, did you want to come in on that point, or was it a different one?
Another point, please, Chair.
Okay, I'll come back to you. Councillor Conti.
Thank you. Really interesting report. I had a couple of questions. The first one was just about the funding, and obviously the discrepancy in Ealing, obviously way below what the average is across North West London. I just wanted to know, I think you mentioned that obviously there's an attempt to level that up. Over what period of time, and you know, in terms of how that's going to sort of be fed in over the next few years? Because the other thing as well that is the number of accepted referrals in Ealing was much higher than the average across North West London, but obviously staffing is the lowest. So in terms of I know you had the performance chart, but I didn't compare borough by borough in terms of how long people are waiting, in terms of how many appointments people may get, in terms of the follow-up. Is that lower in Ealing because of that higher accepted number of patients per 100,000 or per 100,000 and the lower number of staff? So how does that relate to performance? And then on A&E and liaison psychiatry and sort of crisis team, the numbers in terms of the number of people actually attending, the rate isn't much higher than, it's below the average. I think it was 5.3 per 10,000, and the average for North West London is 5.4. But obviously the wait is disproportionately longer. And obviously, you know, you spoke about getting 2 new band 7s and a consultant. How long would you expect the wait time to decrease? How long will it take to get to a more reasonable? Because I think there was some people, what was the percentage? It was more than 72 hours in the hospital. There was still 18 patients waiting more than 3 days. That sounds like an extraordinary amount of time. So when can we expect that to come down? And over what period?
So I'll take both of those questions if helpful. So the first is regarding the disproportionate funding. So it's worth acknowledging that the funding position that West London Trust has for mental health services is a legacy of, you know, over a decade of investment decisions by the commissioners, who historically were using resourcing allocations that were calculated in a darkened room somewhere in Whitehall, I think, which in some cases made the amount of money they had available to them to commission services inequitable. We are working really closely with the ICB and the new larger ICB to try to address this. We've done this in a number of different ways. So one is to look at opportunities for levelling across immediately. That is unquestionably a controversial thing to do. And one of the reasons it's a controversial thing is North West London as a whole, in terms of mental health investment, is already under-resourced compared with a lot of other ICBs in other parts of the country. So even the best resourced of the North West London boroughs arguably is not adequately resourced. So to then reduce the resourcing in order to level up another borough is a very problematic decision, and of course politicians will have views on that particularly. We've taken an approach where any new investment that comes, particularly to West London Trust, I am very strongly advocating that this goes to the boroughs that have lower levels of investment. Now, from the Northwest London, well, from the West London Trust, that is unquestionably Ealing, to a certain extent Hounslow, but particularly Ealing. I know our neighbours are also focusing on similar patterns of investment around the Brent area as well. So for me, whenever we get new money, I do my best to bias it towards delivering the service that is being commissioned, and also making step changes towards how we can address some of that historical inequity. So the 2 examples that have happened in the last 6 months have been additional resourcing, recurrent resourcing that has come into the trust for our crisis pathways. And we have biased that investment. I've put a little bit in Hammersmith and Hounslow, but the majority of that is coming to Ealing and is funding some of those things that Sharon has described, including front door liaison, diversion pathways, additional crisis response capacity, and also additional medical staffing in the Ealing department. So it's happening immediately, but I'm not going to be able to fully close a gap of that size in one go. We are doing the same thing with every additional incremental investment, including talking therapies investment, including any other money I can get my hands on. To be honest, Ealing will be. I will be doing my best to try and level across that investment. We do have the data for all the other indicators around not just demand, which is the referral numbers, but also activity of our teams. We're moving intensively as a trust to try and measure outcomes better, because of course activity doesn't always get people better. We need to make sure that we're measuring our people having a meaningful benefit from our interventions. What I can say is that Ealing, those 2 graphs that we've illustrated are actually the kind of reciprocal of each other, because the more referrals you accept, the less investment there is per 100 patients on your caseload, almost as a direct consequence of having accepted more referrals. But we also have a more productive borough, so they are working harder in Ealing than in the other 2 boroughs. which is another reason why I believe I can afford to invest more in Ealing, whilst the other boroughs can improve their activity through being more productive. So that, through my lens, looking at all three, that's how I'm addressing it. And then finally, and sorry to make this a long answer, in the emergency department, I think there are a number of factors driving length of stay. Clearly, it's unacceptable. I'm a liaison psychiatrist by profession, so this is my bread and butter, thinking about how the emergency department flow should work for patients with mental illness. We've got a lot of evidence to suggest that a significant proportion of those people who attend ED also have comorbid physical health problems, including as a result of their mental health condition, because they might have harmed themselves or come to harm as a result of their mental health challenges. And that has to be a priority. We do our best to work in parallel wherever possible. So we're not waiting for someone to have their medical treatment before we start, but it's not always possible. The second issue that we have in A&E with length of stay is about the clinical decision making, and this goes to the heart, I think, of the leadership changes and the reduced assessment duplications that we have across the different bits of the crisis pathway, because we will often, and I'll give you an example, we often have a patient who will wait in the department for an unacceptably long length of time, let's say 2 or 3 days in the department. That's a rarity, but it does happen. And then at the end of that, a decision is made to discharge them home. And that completely perplexes my Attrued Trust colleagues. How on earth has this been allowed to happen if they could have gone home? Now, the clinical answer to that is actually sometimes that prolonged period of assessment have changed the circumstances. The individual may no longer be intoxicated, may have had some sleep, or the distressing circumstances that led to their presentation may have abated in a different way. That's why we're investing in alternatives. They call them in the press the mental health A&E, but we're preferring the terminology of mental health crisis assessment service, where we can take people off the clock to a calmer space where they are not occupying a cubicle that would otherwise be occupied by someone with pneumonia or something else, in order that we can provide an assertive intervention and hopefully divert someone from the crisis pathway deliberately rather than but kind of by accident. I think I've observed, my hypothesis is that we've got a number of crisis alternatives in Ealing, including the Crisis and Recovery House, including our safe spaces, including our crisis and home treatment teams, virtual wards effectively for people. And I think there has become we always prioritise patients that are high risk and that are detained under the Mental Health Act. We have a higher proportion in Ealing ED of patients being recommended for an informal admission. And as a result, they get deprioritised over those who are being admitted under the Mental Health Act, which is why they're waiting longer. So some of this all boils down to clinical decision making and clinical leadership. And that's why we're making some of those front door changes that were happening. You asked the specific question, when is this going to get better, which is an absolutely appropriate one. We have had to put in a medium-term plan that covers this year and the next 2 years that follow. I am working with my teams and with the trust to try and eliminate those 72-hour breaches in the next couple of months, and actually to get the performance for our 12-hour performance certainly in line with the rest of Northwest London during the next quarter. So that's the sort of timeline that we're working on and that we've committed to with NHS England.
Okay. Looking at this side of the room, Kerry, did you still want to come in? I'll come to you, and then I've got David and Goulet.
Thank you, Chair, and thank you, colleagues, and apologies I can't be there this evening. Councillor Conti very ably asked my question, I think, in terms of the significant variances in funding and the demand levels. I was really interested in Chris's response with regard to the efficiency of the system. So we're low funded, high activity, and it's driven high efficiency in the system. And I'll put that hugely down to colleagues within the trust and also within the council in terms of the partnership working. So with the question about resourcing already been asked, I was going to ask Sharon and Chris a question with regard to deprivation and increasing levels of deprivation, and where you see that taking us in terms of demands in mental health services in the coming months and years.
Sharon.
Yeah, thanks, Kerry. I suppose being close to operational services, we do see this, and I'm sure council colleagues are seeing it all the time. And I suppose we've got high hopes for Hestia and the new offer, which is co-located around, with the crisis team to really address some of those people's access to benefits. Are they optimized financially? That kind of financial budget and support that people will often need. You're probably aware, Kerry, we've done some joint initiatives with Ealing Local Authority Council. We have housing officers now co-located within our ramp service. We've done some joint initiatives with Ealing Rise, and we have dual diagnosis workers both within our ramp service and our community rehab service to try and address some of that prevalence, particularly around substance abuse, sustaining tenancies, because it's tragic if someone with mental health needs loses their tenancy, and it shouldn't happen. And that housing officer has been, I know it's one person and we want to do more, but the impact that we're already seeing around movement from our crisis recovery house through housing pathways. The ramp team has also rolled out quite a lot of training and support to our teams around the legislation around sustaining housing. I think we have a long way to go. I think families are really struggling from a social perspective, but we're trying all sorts of initiatives jointly with partnership agencies to try and address some of that deprivation.
And could I just add, I think there is a well-established in literature connection between the socioeconomic climate and presentations with mental distress. And I think we have Ealing is the borough with the third highest population of homeless after Camden and Westminster, and we observe different patterns of mental health need and demand according to the different levels of socioeconomic status in different parts of the borough. We have worked in the past with public health data to try and help us understand that better and see if we can adapt our models in line with it. And the only other thing, you've mentioned 100 acronyms in your presentation, Sharon, as we always love to in the NHS. One that we haven't mentioned is another service that the Trust is commissioned to deliver, and we do deliver, which is the individualised placement and support to help people both retain and gain employment alongside their, despite their mental health challenges. And individuals can access that service through our mental health pathways. There's a primary care and talking therapies equivalent as well. And I'd really put a plug out for supporting people with employment as a factor driving people's well-being.
Thanks, Chris. Kerry, I'll let you come back in.
Thank you, Chair. I very much appreciate that. I have a real concern that the demand levels are high, the efficiency is high, which is really good, but the funding is low. And with increasing levels of deprivation, how long as a system can we remain efficient? There's only so much more that can be squeezed from the juice, as it were. So I just think it's a really important one, Chair, for us to keep an eye on, or for you to keep an eye on in the future, because as demand levels increase with deprivation, we're certainly seeing that within the adult social care service, and I would have a concern for the future.
Thanks, Gary. I think that's helpful and good advice for the panel moving forward to keep a watch on that. I'm going to go to David, then I've got Goulet, and then I've got Councillor Baines, and we'll have to bring the discussion to a... Did you want to come in after? Yeah, no worries. You'll be the last speaker then. Great.
Thank you for the report, and thank you, Councillor. In the past, and hopefully in the future, Health Watch and the Trust have had a good relationship when it comes to engaging those who use face-to-face mental health services, like inpatient services at Westmid and Charing Cross, and the step-down services throughout Ealing. Given that the engagement landscape is changing, and given how people access mental health services is changing, I was wondering if there's any sort of plan on how to engage with those who use online services like talking therapies, because like 8,698 just through 3 quarters is not an insignificant part of the Ealing population. Thank you.
Chris.
I think we do have a co-production engagement strategy within the trust, which covers our attempt to and our partnership work to support engaging with individuals that use all of our services, including where they're accessing our care through not a face-to-face channel. I'd be really happy to pick up a further conversation, David, if you think the Health Watch can give us some tips in this space, because by no means are we experts in this. We also are doing our best to make sure that as an organisation we're working not just with individuals but their carers and loved ones, family members. The Trust last week was informed that we had progressed through a gateway to become the second step in our journey around the Carers UK work to gain Triangle of Care accreditation, the triangle being the third part of the triangle being the trust, the patient, the third bit being their loved ones. So David, let's continue that conversation around how we can support. Okay.
That's great.
Definitely, thank you.
I'm going to move it.
Oh, sorry.
Sorry, thank you. So Gule, you're next, please.
Thank you very much for the report. My question is on the slide of the flagging performance. Given the numbers of waiting for first and second contact and the cases unflagged and that are open more than 1 week, plus service users with no contact for over 90 days, what specific time-bound actions will you take to ensure every open case has a documented risk flag within 1 week, guarantee contact within 14 days aligned with equity, and proactive, inform and involve the named unpaid carers when contact is missed or risk status changed, with monthly public reporting by borough and service line? And finally, Chris, you already touched on a very good example, which I've actually been through. I have a lived experience of taking a sibling to ED with psychosis and being discharged back home within 3 days with no unpaid carer support, no information on what services to contact, and I had to sort that out myself and contact adult social services and other services. What measures have you put in place since you're making a decision of moving towards the triangle? What actions have you in place for that to proceed and that not to happen again?
Thank you. Briefly, I think you're using some of the data that we've included in the pack, which I think we'd illustrated as the methodology for monitoring, but I'm not sure that the screenshot that's been provided represents the specific data for this borough or for any one of our teams. So I'm happy, apologies to correct that. That's something that I only noticed while preparing for this evening's discussion, but the principles are valid. Obviously, we have a number of referrals that have come into our service at any time. There are 10,000 patients on our community mental health caseload across the 3 boroughs at any time, and the referral to treatment time median is around 3 to 4 weeks across most of our teams, which is within the target for routine services. So at any one time, we'll have a proportion that will not yet have been seen, assessed or flagged. Clearly, we can prioritise those that are flagged to us as urgent in a different way through different pathways. So there are actions in place, and we're currently using the dashboard similar to the one that you've described with live data to enable us to monitor. And if you click through on our version of it, you can see the names of the patients that have not yet been seen, and you can filter it by team, by caseload holder, etc. And managers like Raquin and Sharon are able then to work out why. At the other end, you described a number that have not been seen for much longer periods of times. We have regularly audited those individuals who, in the kind of NHS parlance you refer to as apparently lost to follow-up. Usually they are data quality challenges where our staff members have seen the patient, have entered information on our clinical system, but have not entered it in such a way that it stops the clock. So we're working with the teams to educate them about how to use our systems correctly in a way that the data doesn't need that manual audit to validate. I'm sorry about the experience that you had as a loved one in the emergency department. Clearly that's not acceptable. We have got protocols with our teams, and we are giving lots of training to our teams, including with individuals with lived experience, to try and help them to understand both how to engage with carers loved ones, relatives, within the context also of the individual's capacity and consent to do so. But even where there isn't capacity and consent, because often they say, don't talk to my loved one, sometimes they are happy for it to happen, but sometimes they tell us not to. That doesn't mean to say you can't talk to us. And we can also provide generic information about the sorts of things that we do that will help guide you about how to contact us. It's certainly the case that our crisis resolution single point of access number will take telephone calls from anyone that is concerned about someone, including a loved one, a neighbour, a relative, a counsellor. And whilst we may not be able to give information back for obvious reasons, we can use the information that we've provided to try and intervene and support. So I'd be happy to talk to you more outside about any other things that we might be able to put in place. But that triangle of care accreditation for us is very important about training our staff to do better.
Thanks, Chris. Councillor Baines.
Thank you. Yeah, due to the high referrals for talking therapies, I was just wondering, is there anything being done with community organisations to prevent the mental crisis beforehand until it gets to a crisis point, especially in diverse areas such as Southall and wards like Mine of Dorm as well? Thank you.
Yes, we do. We use quite a few organizations, Asian Family Counseling in Southall being one of them, very culturally sort of sensitive, use different languages. We use other organizations, each, you probably are aware, again, very culturally sort of informed and sensitive. The other organizations we use fairly regularly are Ealing Abbey Counseling, Metanoia. So we do work with a whole range of other community services based on the need of the patients. But organization like Asian Family Counseling is something we use quite regularly.
Thank you very much. Connor, final question from your good self.
So I've only got 2 questions on this report. The first was, do we know what ratio or percentage of the number of referrals, the number of ED attendances and the attendance rates are neurodivergent? Because in my experience, that can require a whole new approach to care, or trying to approach things a little more out of the box, I'll say. And my second question was, if someone's having a mental health crisis, their first instinct, or their family's first instinct, is going to be to call 999 or 111. However, 99 times out of 100, you're just going to get a standard EMT paramedic team show up. And especially in Hanwell, so many of their cases day to day are mental health, and they are not well equipped at all. So would it be possible in the future for the NHS to try and create a specialised mental health team who could be better equipped or have better training to deal with these potentially severe or even dangerous mental health cases, especially as a lot of the time the police could refuse to attend because they don't believe it to be dangerous, or they may not have the resources, so the teams would have no real backup.
Thank you, Connor. 2 really important questions there. Chris, I suspect you might need to come back with the specific data on neurodivergence.
So what I can say is I'm happy to go back and see if we have the exact number on the neurodivergence, but we do have a specific team that works alongside all of our crisis pathways to support individuals on the autistic spectrum, and to support our staff to make adaptations to provide more accessible care for individuals with neurodivergence. We've been through that team, particularly on our inpatient and crisis services, identified more than we were expecting, and they may not be a surprise to anyone else, but we did identify a significant proportion, and they've been providing training support and often work alongside our crisis teams to make sure that we can adapt care appropriately. On the crisis bit, agree with you completely. People do phone 999 111. A couple of years ago, we worked across London around 111, and there is a new initiative called 111 Option 2. Spoiler alert, it's not quite as simple as that, but if you follow the menu options, it does take you down the selection for if you have a mental health need, press 2 eventually, and they actually transfer the call to us. So it's you've dialed 111 and it comes through to West London Trust, and our crisis staff are then able to not only access records for people that we know in our area, and it knows where you are because of your mobile phone mast, etc. But also we can then call upon a whole range of our services to support, including that team that you've just suggested is exactly what we're investing in at the moment. So we've already had our crisis resolution and home treatment team, which provides a kind of virtual ward for people instead of hospitalization. But we're also investing now, it's live, in a team that can respond more quickly in exactly those circumstances where there is an immediate risk of harm. We will send out one of our or a group of our staff to try and either work with the police or the ambulance or instead of, and try and do an assessment straight away.
Thanks very much, Chris. So I think I'd say two things in summary. So thank you for kind of honouring the Trust's commitment in terms of investment in crisis response, because that was something that for those who've been with the panel for a while will know that when was a discussion about the Ealing mental health beds, that was something that the panel really wanted to see. So really grateful for that, and we hope it yields the sort of improvements that you've talked about. And then I suppose a softer point, but important nevertheless, I think the work that you're taking forward, particularly around trauma-informed approaches, is really important, and it's something that I would personally like to see spread right across the health service. It's something that we talk about a lot in a regulatory context, but it's really important so that people are not having to repeat their story over and over again. So I guess my ask, if you like, is to think about how the good work that you're doing, which is good practice, can be spread right across the wider system, looking at frontline staff operating in hospital settings and GP surgeries as well. So, but thank you for your candid responses and openness in answering the panel's questions tonight. And I know there were a couple of points that we'll follow up on in terms of data as well. Great. In which case, colleagues, we're going to move on. The next item 7 on the agenda, is around immunisations and screening, another chunky item. I'll pass over, Anna, to you in the first instance, just so that you can introduce the team who I know are moving as we speak. So Anna, over to you, but it's lovely to have colleagues from your team, but also from NHS England with us as well. Anna, over to you.
Thank you, Chair. Good evening, everybody. So we've brought here an item around particularly focusing on school age immunisations. I think we'd agreed with the panel, had requested that the council has a statutory function about assuring ourselves, our councillors, that we are protecting the health of the residents, and a lot of that is done through our work, a lot of that's partnership work. So Miho and Cyril are here from our team today and can introduce themselves in a minute. And we've also got Susan Eldon. Welcome, Susan, who's one of our very valued colleagues working at the regional level, who's going to touch on that. So Miho's just going to give us a very, very brief verbal summary of the overarching paper, which is a very brief overview of the picture around immunisation and screening uptake, the partnership work, really importantly in Ealing around these areas, really, really broad, and then to try and have a narrow-ish focus, really focusing on the importance of school age IMS, and Susan's going to take us through a presentation through that, and then we can channel questions after that, if that's all right. I did just want to briefly mention, Chair, I know there's a lot in the news at the moment around both measles in North London and meningitis with the Kent outbreak and the very sad deaths. We weren't intending to go into a lot of detail today, but Miho's very kindly agreed to just do a few brief lines of key messages for the panel if the panel's interested, we will be sharing wider communications and messages through our UK Health Security Agency colleagues, and can touch on that maybe at the end of the item. So Miho, so do you want to introduce yourselves, and then I'll hand over to you, Miho.
Thank you, Chair, and thank you, panel, for this opportunity to present this today. As Anna mentioned, this is the annual update on immunisation and screening programme as part of the kind of health protection assurance function. Cover report, we provided within the cover report kind of general updates on key immunisation and screening programmes covering all ages. There are many important actors in delivering immunisation and screening programmes, and so the partnership works really key. And in Ealing, we do this through Ealing immunisation groups and quarterly cancer screening meetings with Health Protection Forum providing oversight and assurance capacity. As Anna mentioned, today's updates deep dive topic is around school immunisation programme. There has been lots of good partnership working happening, developing locally in Ealing. So this is a great opportunity to perhaps touch on some of that. The partnership work in school immunisation settings particularly important because obviously we're working with individual schools with different needs, and so local partnership has been quite important. Cyril here is also here from the team, kind of public health lead on immunisation programme, but I'm going to just hand over to Susan to take us through kind of from the regional perspective on the school immunisation programme, which she oversees the kind of commissioned school immunisation service.
Thank you, Miho. Thank you, Anna, and good evening, colleagues. So I'm Susan Eldon. I'm a public health consultant working in NHS England, London, and primarily in the vaccination space. And we wanted to provide an update, not just, on vaccination, but specifically on adolescent, because right now is when we're doing the adolescent campaign throughout schools across London and countrywide. So right now in schools, children will be getting adolescent meningitis, a teenage booster, and the HPV vaccine. What I'll do is just quickly go through a few slides, and I'll be pretty brief because I know you've had a lot on the agenda, but just to flag, first of all, as Anna and Miho said already, it really is, although NHS is the commissioned provider, it really is a partnership approach. So the UK Health Security Agency, Ealing Local Authority, Northwest ICB, and ourselves in NHSE London really have to work closely together to make sure, because it's not really about just the vaccines and the delivery, but it's really also about the demand, the inequalities, very similar themes about the community's disadvantage, and making sure that we have adequate reach and access into all of the programs and to the communities that need it most. So again, just going to focus quickly on the adolescent. So this doesn't cover, as you know, the key childhood and infant course, MMR, and the primary course and all of that. And then of course, we have a massive older people agenda, and then what adults get. So this is just narrowly focused on the school age vaccination children. And so those of you who either are parents or know of children in school, hopefully across all the secondary schools, this, you will see this happening now. I will say that the other thing that we do with school age vaccination that is vitally important, that we do every year, is the seasonal vaccine. And this has expanded over the years. So in the past, we only used to do a narrow cohort of school age children, but that has now expanded into secondary school children. And you can see here in this, Ealing remains at the lower end. So London flu overall is lower than the England average, and Ealing, although it has improved, I will say these are, because this is a public forum and public documents, the published data is from 24-25, but the previous year, which will be when we conducted this in November and December, there was a 3% increase in flu vaccination in Ealing. So it is trending upwards, but again, it is lower than we would like it to be, because that is vital protection against transmission of flu and hospitalizations. But that is a real testament to the work of local authority partners and really all the advocacy efforts working with head teachers and everyone to bring up those rates. So again, it's below 40%, so not as good as we would like to see it. We would like to see higher coverage, but amongst the Northwest London average, it tends to be a little bit higher. So currently, and as Anna mentioned, measles is very much in the news, and that is the outbreak in Kent is a different strain, but what we provide to all adolescents is a meningitis ACWY, which is a bacterial strain which covers all of those. And you can see again, one of the challenges has been, since this program has delivered, you see Ealing here in the dark blue bars, it is trending upwards, but against a much higher England and London average. So again, Ealing is higher for the Northwest London average, but it does remain lower than London and England. And then I think, you notice this bar here is 90%, as we really need at the population level to have good coverage of the whole of the population. So regardless of where these bars are, I think that we will not be satisfied until we are at 90% and have adequate protection for, all of those children and groups. So this again shows Ealing's placement, and this is last year's campaign. So we're currently doing it now. So we'll have figures hopefully in the coming months for where it is currently, and it is looking improved already, although we don't yet know because the data is still coming in. But again, only about 54% of kids are covered for meningitis ACYW, and that's a real challenge when you think that a little bit under half of the kids are not getting covered for that vaccine. The other one is the school leaver booster. So this is it kind of mostly we care about it for polio, but it's tetanus, diphtheria, and IPV, but it's basically the teenage booster. So this is the last one they get in that childhood course there. And again, the patterns are very, very similar for meningitis. So meningitis, the booster and HPV tend to be trending around similar. So again, here you can see it's 54%, and again, where that falls within the region. And there is a real distinct trend where the south of the river, and particularly the southwest, is higher than the England average, but northwest London tends to be at the lower averages. I wanted to spend a little bit of time just talking about HPV, because this is again a really vitally important protection against some cervical cancers and a number of cancers. And we have an NHS target to eliminate cervical cancer by 2040, and we are falling well short of that, both nationally, regionally, and across London. So you can see here that London is the lowest, and our coverage is well below 70%. There is an overall declining trend since the COVID pandemic across all childhood IMS. There was a sharp drop during that pandemic area, and it has really struggled to recover. We know that boys are lower than girls in all regions, including London, and there's a number of inequalities. And there's significant, as you will know, both in Ealing and in all boroughs, there's significant variation across those groups at the school level, at the geography level, and right down to the neighborhood level. So right now our HPV vaccination coverage, and this is for the year 8 children, but we offer top-ups to year 9 and year 10, and then children can come to a GP for an evergreen offer for all of these vaccines up to the age of 25 at any point. And we also do catch-up clinics in all of the areas, so those are advertised for any child that's missed or any child that wants an appointment. But again, you can see here that Ealing again is on the lower end of the London average, but it tends to be around the mid-range of the Northwest London average. So again, I think that this is a kind of a wake-up call for us, that with these trends well below 50%, that this is something that we really need to have a more dedicated borough level approach for. We've been speaking to our providers, to all of our partners and networks to see about what we can do to improve that through access, innovation, community engagement, and workforce. So there's a number of strategies in place, and I can speak to those if there are questions. But just to say, when I say our focus for next year, this was actually done in December, but our focus for this year is really how we monitor that performance at a really granular level. We make sure that our advocacy, our community engagement, our faith groups are much more embedded and integrated into that offer, that we have school webinars, that we have much greater access into those head teacher forums and ways where we can work closely with schools. The other big area for us is catching up on these non-response rates. So where parents may or may not see the consent to vaccinate, it's really about making sure that reminders are sent frequently and repeated offers, and then making sure that we have clinics in a variety of other accessible locations. So it's really about pushing out that access. So we have a dedicated HPV plan. We're closely monitoring it. We have a strategic group in place and a number of different performance targets that we're doing to monitor that. Again, I think finally, just to say, the local partnership work. So the only way that we're able to get as far as we have gotten, and I would say it's not far enough. So I think we're very much keen, excuse me, keen to see that we are going to continue to see those improvements, but at a higher gradient. It's just a huge thanks, because it really does need all of the stakeholders from the voluntary sector, the local authority, and everybody putting in. So this is just some of the examples of how that partnership work happens throughout the cycle of vaccination. And I just wanted to also just say in closing that, you know, these issues and these trends relate to Ealing, but they also relate to some of the London and the national trends, because we know that there's a number of societal and structural trends and challenges with vaccination uptake. It's, you know, the Ealing picture is against the backdrop of a widening inequality lens and a lower uptake lens. So this is something that is a much bigger system and societal challenge for us. But we also just really wanted to thank the Ealing Public Health colleagues, all the voluntary sector colleagues, and also I know that the Ealing councillors and elected members have been doing a lot to also advocate and support that. So our huge thanks to those, and happy to take any questions. Thank you.
Thanks very much, Susan. I've got indications in the room. Before we do that, I'd just like to ask the kind of obvious question first, using Chair's prerogative. So if you look at the graphs that you displayed, Richmond and Kingston come out on top. What are they doing that we're not, I suppose, is the obvious question.
Yeah, so I mean, this has been a historical aspect in that it's not a linear or a causal relationship, but there is certainly something where areas of deprivation and areas of inequalities at the borough level and the sub-borough level are remarkable in this respect. I think there is something about Richmond and Kingston in particular, and we have been speaking to the teams and the school-based providers, and what they tell us is that there is a huge enthusiasm from schools and there is a dedication from those head teachers. Now, some of those relationships in Northwest London, because we have a newer provider that has come in, so I think that some of that contracting has changed. But when I have actually been out myself on vaccination visits, we do spot checks. One of the things that I've noticed is in a school, I think it's also the school environment, and I think it's deprivation and inequality. So it's a little bit multi-causal, but where we have schools that are deeply engaged, the heads are engaged, the communication goes out to parents, we are seeing a higher rate of response. But it is, yeah, I think some of it is geography and some of it is inequalities. But I think if you were to look at screening uptake and similar trends, you might see other patterns that wouldn't just be related to this. We see the same thing in flu. We see the same thing on other aspects of cancer screening, those types of Borough trends.
Thanks, Susan. So Anna, you wanted to come in on this, and then I've got a queue.
Thanks, Chair. Thanks, Susan. I think the slide slide 12 in the pack with the boxes, I think is really important. I think there's a lot from the delivery side, the partnership working with schools, particularly with this instance, making access easy, making things understood, delivering things different hours, etc., etc. So key. The community engagement is a big part of what we do as well. Partnership work, not just for school AGMs, for all of these. And I think Miho had covered some of that in her report as well, in terms of some of our work with our local voluntary sector, some of our work with West London Trust. So really about just having those community conversations with individuals and families. I think trust is a massive element of that. Different immunisation schedules in different countries, etc. I think there's so many different aspects of this. It isn't just about how do we deliver immunisations on the ground, and I think it all needs to come together. There's an awful lot of London work, so we work with Susan with more of a strategic hat as well. There's a lot of London work coming out of COVID, particularly around different communities, having those conversations about vaccinations. That is so important, and we pay into those regional community engagement approaches as well, because I think they're really important. This isn't just about Ealing as well. A lot of our communities cross over different borders and things, so I think it really is that partnership work around, but that is a big issue for us.
Can I just check? So I've got on my list, I've got Goulet, I've got Councillor Dinser, I've got the cabinet member, I have got Councillor Conti and Councillor Baines. Is there anyone else that wants to? And David as well, and Councillor Mataza. So I've got the whole panel. Right, Goulet.
Thank you very much for the report. And as a very concerned unpaid carer, I'm raising the case again of a housebound 41-year-old paralyzed adult patient with complex needs, living with two older relatives, 88 and 71 years. Again, for the third year, she didn't get her pneumococcal vaccine, an RSV vaccine, after getting her text message, which she gets annually for the last 3 years. And during this course of 3 years, she's had 5 pneumonia admissions at Ealing Hospital. And what I would like to know is, since your last report where I raised this, what time-bound actions do you plan to take to provide home visit vaccination catch-up and respiratory care plans, fix the recall outreach system for housebound high-risk adults, name an accountable lead and escalation route for missed vaccinations, and publicly track vaccine uptake and pneumonia admissions by borough? My second question is to do with Ealing Hospital. Can Ealing Hospital implement check and book for adult vaccinations, flu, pneumococcal, shingles, where appropriate, at emergency, outpatient and discharge points? And can Ealing Hospital staff check if the patient has had the pneumonia vaccine before they discharge the patient? Community-acquired pneumonia is very, very common in Ealing. And this is one way where we can capture this. And if Ealing Hospital can help to provide some kind of service to tackle this, it would be great. And my last question is to do with the recent outbreak of meningitis in Kent. I am a university staff member, and we've got a lot of anxiety among our students and among our staff as well. The reason I'm raising this is, like last week, I was looking for ciprofloxacin, one of the antibiotics that's been given out at Kent University students, and I couldn't locate it in 3 pharmacies. It was out of stock with the wholesalers until I went out of the borough to get it. So what is the borough doing to stockpile in case we do have an outbreak of meningitis? Thank you.
Thanks, Gule. So I think on the first question, I'll come to you, Neha. We haven't got anyone from Ealing Hospital present, so we might need to take that one away. And then Miho or you'll deal with that as well, Neha. That's great. And then Miho and Anna on the meningitis point.
Thank you very much. I know that first question is about a specific patient, so I don't really want to answer that specific patient, but I will take a conversation with you separately and provide a response about what is happening, what's going wrong in that pathway. But we've changed it slightly. So how does the ICB track pneumococcal vaccine uptake and pneumonia related admissions? So the ICB typically relies on both national and local data to monitor vaccine uptake. This can be via systems such as Inform, which is an online platform used by the Department of Health to collect data on vaccine uptake and manage vaccine orders for national immunization programs, or via data taken directly from GP clinical systems. All hospital admissions are closely monitored on a regular basis. The ICB, as well as acute partners, so the hospital, specifically look at non-elective admissions related to the exacerbation of respiratory diseases. Healthcare providers can also access data provided by platforms such as the Respiratory Electronic Submission Platform, RESP, that report data on respiratory diseases. So that's the first ones, which I've just personalized, but as I said, I'll have a conversation with you afterwards. With the second question about Ealing Hospital, Ealing Hospital is able to access patient information for direct care, but it would not be appropriate to implement a check and book process as suggested. Call and recall alongside the delivery of vaccinations is the responsibility of primary care services, so GP practices, and the duplication of that role would not be effective use of much needed secondary care resource. GP practices are required to review patients post-discharge and would review vaccination uptake as part of this. GPs would be better placed to understand and address specific patient variables such as contraindications or hesitancy, which may not be apparent in a hospital setting.
Thanks very much, Neha. Anna?
Yeah, Chair, just a query back to you to check if it's helpful for Gule's question to come back at the end, because I think if we give a bit of the context first, because not everybody will be aware, and then I'll answer your question then, if that's okay.
Absolutely
Thank
happy
you.
with that.
I've saved it.
So Gule will come back to that at the end. So I will move to Councillor Dinser.
Thank you, Chair. It's a quite informative report. There are a couple of questions I'd like to ask. What are the main barriers to childhood and teenage vaccination in Ealing? I think going back few years to the COVID time, I think we faced similar kind of situation where we was trying to understand whether it's cultural thing or whether it's success or whether there's misinformation in the community. So just want to understand what are the main barriers, and also want to understand, the community with the lowest uptake, how can we engage with them, and how have we improved since the COVID? Because I think these are the same questions which we were asking during the COVID time. What progress have we made in these 4 or 5 years?
Yeah.
Thank you. So what are the main barriers? I think Susan touched a little bit on that in terms of kind of borough differences, but there are multifaceted and various different reasons. And so we, for the last year and a bit, we are piloting a community, so raising awareness, community engagement function around specifically around immunisation in Ealing. And what we are learning through that sort of feedback as well is that, there are various reasons, and sometimes these reasons are different in different communities and culture. And I think that highlights the kind of really importance of that community engagement approach. And so not just through school kind of usual information route, but really having a conversation with the communities to try and understand what what's the kind of cause, what's the barriers they're facing. It may, some of the cases, it's just simply a practicality, and we are trying to eliminate as much as possible, so making immunization services as accessible as possible, and working with the school immunization providers as well in terms of catch-up clinics. So we have as much catch-up clinics. We're trying to increase the catch-up clinics as much as available so that they can access it. So yeah, I think those are the kind of two areas that we're trying to work on, and particularly the community engagement function, or the service aspect, is relatively new after the COVID. So that's sort of something that we learned from the COVID and wanted to implement.
Thanks very much. Councillor Dinser?
No, I'm just trying to understand, do we have data which are the communities with the lowest uptake? Because if I see around my colleagues, they are councillors from every community. We can use them as a platform to engage with the communities. I think that's what needs to happen. Whether we are, I'm not saying we are doing wonderful work, but we're still not meeting the target. In order to achieve the target, we need to look outside the box and make use of the resources which we have, like councillors or other community leaders. That's what I'm trying to get at.
Thanks, Councillor Dinser. So Miho and then Susan.
Thank you. And I think the community engagement function really tries to do that. So the function sort of service reaching to faith communities, as well as community groups, to voluntary community sector, community groups, to try and raise awareness and having conversation. In terms of the data, unfortunately, the data is usually collected at, for example, school level or GP level. And unfortunately, it doesn't really go down to a really meaningful way of looking at which ethnic group. But also, I think there are various different reasons when it comes to immunization. So, we're trying to kind of tackle that from multiple different angles.
Susan, is there anything at an NHS England level that can be done about the data?
Yeah, so and that's a really helpful question and point about this. I mean, one of the things that we have as a challenge is around data and data flows, and this links back to some of the mobility and also the international dimension of Ealing. So, for example, we've taken a couple of practices that we knew had lower uptake, and we've done a deep dive into those to try to understand what some of the barriers were. And some of this is, people who come from Brazil, Nigeria, other places that may have a different childhood schedule, and that's just a recording issue. There are other things where, the recording of that ethnicity or certain demographics aren't recorded, and either people aren't comfortable with that. But somewhere around, I think it's around 80% of our records aren't really coded for ethnicity. So that is still a challenge, although we do know that there is huge variation. I think the other thing that is that comes to light is, what vaccination used to be 10 years ago. Just in the past 3 years, we've introduced a new gonorrhea vaccine. We've introduced the respiratory syncytial virus for pregnant women and older ages. And we've also changed the schedule for the childhood schedule. So it's become much more complex. And so even while we see this expansion, but there's a lot of times that even the public can be sometimes confused on what vaccinations they need when. And so it's also important that we reinforce that. And one of the big areas that we're trying to work with NHS nationals to improve that digitalization. So just like COVID and flu have a sort of an app and an interface, and you can see that data flow, a number of the other vaccinations haven't come up to speed with that yet. So that's a real massive agenda for us as an NHS system to try to get better at, having that digital interface and having that data flowing around patients. Thanks.
DJ, is it on that point? Yeah,
just really it's primarily around sort of general practice perspective in general around vaccination. So each GP practice in England have performance targets around, particularly in relation to childhood vaccination and shingles. So with regards to childhood vaccinations, what we generally find in general practice is that we tend to have a very good uptake for the childhood vaccinations before the age of 12 months. What we find that we definitely do struggle on is the preschool boosters. We tend to find that either the parents have got somewhat vaccination fatigue in terms of bringing children in for their preschool booster, but also what has been picked on is that particularly in Ealing, we find that we have a lot, because we have a lot of migration in Ealing, we tend to find that children from abroad may or may not have had vaccinations abroad, but we struggle to actually to understand and determine what they've actually had. Patients and the parents are not forthcoming in terms of providing us information in relation to their children's vaccination history. And clearly, we have a catch-up program for those children that we don't know what they actually have had. However, the parents are then reluctant to bring them in because they've had something in the past and they don't want that child to have another vaccination again. So we do face quite a lot of challenges in general practice, really trying to improve the uptake of childhood vaccinations. The other area I just wanted to pick on is the seasonal vaccination. We are finding in general practice that there is a significant wastage of the flu vaccination year on year. And that is partly to do with the fact that, again, we are finding that we are struggling getting those under 65s who are at risk, who are entitled to a flu vaccination, to actually come in, despite a lot of efforts from individual practices to encourage them to come in. And every practice in Ealing and across Northwest London are finding that they've got a stockpile of flu vaccinations, which then expire at the end of April, because we just cannot get these individuals just do not want to come in for their flu vaccination. Pneumococcal is a one-off vaccination that's given from the age of 65. It's not a vaccination that's done on a seasonal basis. So generally speaking, the uptake of pneumococcal is good because it's a one-off vaccination. We target those individuals once they reach just age of 65 to come in and to have their pneumococcal vaccination. However, that does not mean that they will get a community-acquired pneumonia. Community-acquired pneumonia has numerous strains of bacteria that cause it. Pneumococcal does provide some level of protection, but there's no guarantee you will not get pneumonia if you have a pneumococcal vaccination. If there are situations where individuals who are housebound, who have a requirement for vaccination, general practice has worked in the past and continues to work with community pharmacy to support some of that housebound delivery. We have used the Northwest London roving team, particularly in relation to COVID vaccination over a number of years. That is a situation which is currently being reviewed in terms of how we look at housebound vaccinations going forward. But it is a joint effort for everyone to try and improve uptakes. Community pharmacy have in fact played a significant they've had a significant approach in terms of how we use vaccination outlets. We've also used in Ealing, our immunisation team have gone out to the schools, as what's been mentioned, to really speak to the parents about why they're hesitant to bring their children in for particularly their preschool booster. It's a particular issue, as well as the MMR has been a particular issue for Ealing. But we continue in general practice, continually remind parents, we continually talk to them, we continually text them, we provide them information about the importance of vaccinations. Obviously, we get these pockets of outbreaks of measles particularly, and we all know how serious measles can be in relation to childhood long-term morbidity. So it's not from trying, we always continue to try that, but as said, it really is multifactorial. The whole issue around uptake, around vaccinations generally in this country. The COVID vaccination, we all know has had a significant impact in terms of survival of individuals in relation to COVID, but there's also been skepticism around the COVID vaccination. Some of that has been overlain with regards to the other vaccinations that are delivered.
BJ, I'm going to have to bring you to a close, but I think we do understand the significant challenges, and I think it's really important that we've had the kind of general practice perspective. Councillor Newster.
I suppose I'm not going to say anything fresh, but like we're aware that we're deploying all these levers and they're still not working, right? And I just wanted to, I suppose, sort of echo and extend Councillor Dinser's point, is that we do have community resource, and I do think, and I feel like I've said this before, as the mother of a child who was the only person in her class to get the MPV vaccination, there are significant elements that we are not doing right. And so, yes, we can talk to parents, but, we also need to talk to those kids, because their hesitancy is not necessarily about vaccines per se or, whatever, but it will be about whether it's the cool thing to be doing in school and whether it's actually seen as something that has nothing to do with them. And I think, again, I've said this before, when I got those communications about HPV, and let's be clear, we can eliminate most cervical cancers in a generation. This is not a nice to have. This is something that we're currently got, just under 700 deaths a year in the UK. That's with all the screening that already happens and all the work and all the investment and all of those smears that we go and have. Even with that, we're still, losing far too many people, never mind the other cancers that it can. So I guess it's a sort of, we're all very good at sitting in rooms and describing the problems of the things that don't work. Like, if we can bring a bit of system-wide pressure, focus, a little bit of, perhaps unorthodox practice around, how do we really deploy the resources we have, we could start moving the dial, because at the level of 40% of our people having the HPV vaccination, when we know that is going to directly result in our young people dying in their later life, it is scandalous and it's preventable, and we all have to have a better role.
Thank you. Councillor Conti.
I think Councillor Newsom sort of touched on the point that I was going to raise. It's one of the things that strikes me. I have these conversations on a weekly basis at work, and I'm sure you do, how frustrating it is where people feel that they get their information from and the reliability that they hold to it. How many times people said, I've seen this on TikTok. Had a teenager last year talking about that, really proud that she didn't have the vaccine because of what she'd seen on TikTok. And I guess the question is are we talking to the right people in the right way on the platforms that they use? Because using different community groups, etc. But for example, the stuff that relates to young people at school, in particular teenagers, and also, for example, the flu in under 65s, are they really accessing community groups and community elders in the way that maybe other groups are, or in particular the elderly? And are we using social media platforms with the right people on there talking the language that young people are using around those issues? Because I feel that's maybe where the void is, because that's where they get their information from. A lot of the time it's wrong. I had one person ask me last week, a few weeks ago, about whether the vaccinations were organic. And it's just like, where, you're reading this stuff online and you think, but they think it's true. It's impossible almost to demystify that. And I think it's because these are now trusted platforms. And when you try and use something else, that's not really the way that they access information, actually that information doesn't come across to them.
Thanks, Councillor Conti. I think it would be good to get an Ealing perspective, but also an NHS England perspective on that question. So, because there's something about the central kind of comms and messaging. So, Miho, Anna?
I'll start off. Thanks, Councillor Conti. Totally appreciate the frustration with that, and it's something we come across a lot, and I'm sure colleagues do as well. I think this is where I mentioned about the London work. I think is really crucial to us at Ealing. With all the best will in the world, our council communications are not going to reach those groups, and we're not going to learn from those groups as well. And I think that's where a lot of our regional work with Susan and colleagues around community engagement, hesitancy, where are people getting misinformation from, I think is so important, because there's only so much we can do at a local level around that. I think there is something though for us hearing more about, you know, from yourselves as local GPs, from teachers, from voluntary sector groups, from faith leaders, about what they are hearing from local people, local young people, local families, I think is important. We probably don't do enough of that. I think there is something underlying this when we take a real step, zoom out, about kind of critical appraisal skills and resilience through schools. I know we've linked through with our 0 to 19 service, our school team that was linked up there, do a lot of that, those sorts of discussions with immunisations as an example. And I think those sorts of that sort of work through our schools is really key on this. Miho, do you want to add anything, or see if Susan wants to come on?
Yes, I think within the last year, we also worked with Health Improvement team to embed the immunization information or within the curriculum of PSHE as well. So we worked kind of jointly with the Health Improvement team to look at it in the kind of mainstream education side of things in terms of kind of sharing information on vaccine. But yes, no, I really appreciate your frustration and kind of suggestions.
Susan, anything you want to add?
Well, I would just say from an NHS perspective, there's a lot of emphasis on sort of the NHS brand and maintaining that sort of safe and effective message and making sure that that reaches the majority of the population. So I think, you know, there's probably a lot less of the kind of, you know, followers on social media, but there is something about retaining and maintaining that trusted space about, you know, this is factual, this is accurate, it is safe and effective, and that can work for the majority. But I also do agree that, you know, people's attentions are drawn to all sorts of things, and I do think that that's a bigger societal thing, where I think that, you know, we're looking at that, and we've done a number of different sort of youth groups and engagement with young people, and there's also a lot of behavioral insights that are done with that. And there is still a lot of so something is we do at schools is Gillet competency. So children who are adolescent can be directly you know, ask about the vaccination. And so it is about maintaining. I think the one thing we're trying to do is really maintain those high quality services, have those questions being answered, and have those patient times, and be able to, I guess, retain that trust where it is there. But it really isn't as dazzling or glamorous as some of the stuff on TikTok. And I haven't seen, you know, how we're doing that as a system on some of those social media platforms to the same extent. So I agree that that's a very worrying societal trend about some of that.
Thank you, Susan. And we might come back in the recommendations at the end around kind of some of the work that we'd like to see in terms of social media. So I've got three questions. I'm going to take them one after the other, and then I'll come to speakers. So I've got Councillor Baines. We'll have to do a quick fire round just because we are running over time now.
Yeah, it's just whilst I was reading the report, I was quite taken back when I looked at cervical screening being in Ealing below national average and declining. So I was thinking, what could be the barriers that women are facing for not going to get checked, and what are we doing to address this? Because for me, that's like, I didn't realise that. I thought there's a lot of adverts going out and a lot of awareness about it, but the fact that it's still below national average is quite worrying. Thanks.
Thanks, Councillor Baines. David, I'll come to you for your question.
So some things I want to put emphasis on, and it's going to make us feel a little bit old, is at the height of the pandemic in 2020, this year's cohort of year 8 students were about 6 years old. So as we keep going forward in time, less and less students that are the vaccine age are going to have any core memories of the pandemic. And as Councillor Conte said, social media is rife with disinformation. When we did our study talking to young people about vaccines at Health Watch 2 years ago with a cohort that had core memories of the pandemic, social media was a big source of information for them, and that's only going to increase over time. One thing I want to touch on regarding HPV is when in our report we had a recommendation regarding specialized educational materials for young boys, because we found when we talked to parents and young men, they only thought the HPV vaccine was for girls. They had no idea it was a co-ed vaccine. So I'm just wondering if any material has been developed, if there's a strategy for young men in particular, because we need to get ahead of this.
Thanks, David. And then Councillor Mataza, I'll come to your question and then we'll go for responses.
Thank you, Chair. Most of my questions actually have been either answered or almost answered. Two quick ones. Is there any data which shows that any outbreak of new contracted cases, are they vaccinated or unvaccinated? So this is very important for two reasons. One, we can actually tell the masses that unvaccinated people get these diseases, or either it is vaccine failure. So this is, if we could get that data and then publish, and that can equip our people who are, for example, primary care as a GP and the stuff. And the other quick question is, since this Kent episode, we are getting quite a lot of queries. Are there any boosters required for ACWY vaccines or meningitis vaccine? Thank you.
Thanks, Councillor Mataza. So Councillor Baines asked about cervical screening. Anna?
If it's okay, Chair, I was going to do it backwards.
Do it backwards.
And then pass on to colleagues if that's
way
okay.
Like.
So,
Yeah, no problem.
so the data on outbreaks is a really good question. So, for example, the more recent outbreaks for measles in North London and more North East London a few months ago, there's a lot of data that shows, I think it was about 80%, 90% of the children who were ill with measles were unvaccinated. And so that data is collected, it feeds into some of the communications, it feeds into the very localized neighborhood level conversations with schools and families and things. But there's numbers of outbreaks like that where that's shown. In terms of the other two questions, I'll pass over to Miho and potentially Susa, but I'm very aware of time as well. So it may be that we follow up with Anna Marie with a few points written, if that's okay.
Yeah, no problem. Miho.
Yes, thank you. So I think there were questions around meningitis. Sorry, we'll come back. Yes, okay, sorry. Yes, cervical screening, sorry, apologies. Yes, so I think the previous update that we brought to this platform was focused on cancer, and there's lots of kind of work behind the scene, particularly led by RM partners in NHS England around looking at inequalities and how they can improve that. So we obviously linking in with that kind of regional team to look at what more we can do around it. There's obviously annual plan of campaigns and things like that, and when they're doing it, we are obviously trying to support that, because it makes more sense to try and do it all at the same time rather than sort of trying it different timings and stuff. But we are very well linked in with the RM partners, kind of leading on promotional activity. Obviously there are various reasons with the diverse population. There are always kind of issues around cultural misunderstanding and barriers to cervical screenings as well, and those are well sort of considered within that platform. Yeah.
There's also an opportunity actually for me to raise that question at the North West London Joint Health Overview and Scrutiny Committee on Thursday, because it's one of the items on the agenda, so I'll make sure that I do that. There was another question just about HPV materials for men in particular.
Go for it.
Yes, I think, again, HPV materials for the boys, I think there's been lots of conversation, and I think the rates of the gap are decreasing between the girls and boys now. So that message has been slowly sort of embedded, I suppose, in the communications. we treat HPV vaccination as any other routine vaccination. So the way that we communicate is the same. So there's no kind of gender differences, etc. And now it's advertised more strongly as cancer prevention vaccination, whereas previously I think there are some misunderstanding around kind of links to STIs, which kind of medical term it may be true, but I think the main purpose of the vaccine is the cancer prevention, and that message seems to be starting to kind of slowly embed it in the community, which I think helps with the uptake from the boys' side as well. Susan, if you might want to add anything.
I think
No,
Susan,
I agree with all of that.
Lovely. So colleagues, thank you. That's been a really helpful discussion. I think just by way of recommendation, one of the things that's really struck me is the need for that kind of continued partnership working between health, public health, schools and the community to kind of work together to improve school immunisation uptake in particular. And I think we discussed at our pre-meet in advance of tonight's panel, the Health Protection Forum just having a close monitoring role and facilitating that partnership working. I actually think there's probably a need to go further in relation to setting up a specific task force, because I think what's been really obvious to me this evening is there's some perspectives that we probably need to make sure are reflected in the strategy moving forward. I think VJ, for example, around the primary care sort of perspective, and I'd like to see some head teachers involved in the work as well to provide some on the ground feedback about their experiences. So I think it'd be really good for the panel to keep a watching brief on this. But just to Anna, Miho, Cyril and Susan, thank you very much for your time this evening, and no doubt this will come up again soon. We're moving on to the next item. I'm really okay.
It's
Very
just
quickly.
a comment, actually, more than anything else. As governors, we can take it back to our schools as well and discuss it at governing bodies and with the head teacher. Thank you.
Brilliant. No, that's a fair point, and I think we should do that. Carrie, emerging from the darkness, you're coming forward. Item 8 is on the role of the voluntary and community sector. Anna, I think you can take the materials as read. So maybe a 30-second intro, and then we'll go to questions. So over to you, Anna.
Thank you, Chair. So we're joined, this is a paper that we've pulled together from lots of colleagues from across the Council, NHS, and with Gurpreet as well from EHCVS. We were asked by the panel to bring this item here. It's obviously very broad, so we've tried to put in some element of structure here to just talk us through what we're talking about, defining voluntary sector, defining what we mean by their role in health services, and particularly the kind of strategic partnership work as part of that, I think is really key. There's an awful lot of, I think when we were talking about it, there's very few voluntary sector organisations we can think of that don't have a role in either service provision, advocacy, information, etc. And there's one very empty slide that just says lots of others are involved in this, apologies, but we didn't want to start listing names because it just involves everyone. So I think for us it was just there is a really strong partnership vision around supporting the voluntary sector working differently with communities through the health and wellbeing strategy, particularly the Council's vision for connected communities, and in terms of next steps, just to touch on really briefly, one of those is our VCSC grants programme that we have between the Council and the NHS. EHCVS obviously a core part of that, but lots and lots of organisations involved. So we really are thinking about how do we maximise the impact, how do we strengthen community capacity, and also think about where else are partners working with VCS on that, and then other things. Was just there's a lot of this underneath the delivery of the health and wellbeing strategy. So real practical examples like consideration of funding cycles, remuneration policy, if people are spending time inputting, that we're treating that fairly, workforce pressures, etc. And really, I think importantly, linking with the neighbourhood health work, really thinking about where you've got GP practices, health partners, working with everybody in their communities, and a really big part of that is our voluntary sector. So that was my speedy run through, but colleagues are here. Marie's also online from who's our interim strategic director, and Carrie here, and Neha, and happy to take any questions back to colleagues.
Brilliant. I don't know how you managed to do that in such a short space of time, given the amount of content in the report, but really grateful. And Marie and Carrie, I will come to you fairly early, actually, because Lorraine Charlton, who is our community and voluntary sector rep, has sent in some questions. So I'm just going to quick fire them, if that's okay. Unfortunately, I think she's had a personal emergency and wasn't able to make it along this evening. So Lorraine says, voluntary organisations delivering commission services are facing increasing financial pressures due to inflation, rising operational costs and workforce challenges. Are there plans to A, review the value of commission contracts and grants to ensure they reflect these rising costs and remain sustainable for organisations delivering these services? B, consider long-term commissioning cycles or multi-year funding arrangements to provide greater stability for organisations delivering preventative services, as short commissioning cycles can make it difficult to plan, retain staff and invest in long-term relationships with communities. Lorraine then goes on to say, the presentation highlights the voluntary and community sector as an important community asset supporting health and well-being. What steps is the council taking to protect and strengthen these community assets and ensure their sustainability, particularly at a time when many organisations are facing financial pressures and increasing demand for services? And then the final point that Lorraine says is many organisations rely on affordable community spaces to deliver services and support residents locally. What actions is the council taking to ensure community organisations have access to suitable and affordable venues across the borough? And I will take a breath at that point. And Marie and Carrie, I'll come to you.
Marie, should I come in the first instance and then we'll go? So
yeah, please do. Thanks, Carrie.
Just in terms of all of those questions, obviously we know that our voluntary community sector are vital locally. We've got an amazing array of organisations and we are stepping up how we work alongside them. And I hope lots of people are seeing that strengthening of the relationship over a number of years. The problems that Lorraine has highlighted, though, are common across the country in lots of ways. So we just need to acknowledge the increasingly challenging circumstances many voluntary organisations are facing, but I hope we're working well in partnership with lots of them. So just on multi-year funding cycles, I think actually if I compare us to many boroughs and places across the country, we do have really strong multi-year funding cycles. So our VCSE NHS grant is a case in point where we've got multiple years, and we're also planning for that recommissioning really far in advance so that it's shaped by our local sector, and that we're hoping to be able to strengthen that work. That includes capacity building work within it so that we're valuing that and the strength of the sector more broadly, and we're having ongoing conversations with the sector about how we can use things like our social value and other areas to really strengthen the support we can offer to our voluntary sector, which I think is fantastic. If I benchmark us, so I've come in fresh, only been in the borough for 10 months, and I have benchmarked us against other boroughs in London, and actually our investment in the voluntary sector is really quite sizable and compares really quite favourably to lots, and we're committed to doing more. There's always more we can do, and we're in that space. So inflationary contracts, obviously that's really difficult in lots of ways because we look across our commissioning cycle. Obviously the broad array of arrangements that we have with our voluntary sector, the individual commissioners need to make sure that they're looking at that and having those conversations. In some cases, it might not be that we have budget to create inflationary uplifts. So sometimes that we might also have discussions about what are the implications for what we might not be able to do as well. So I hope, and I speak regularly to commissioning colleagues across the council and also with our NHS partners where we revisit those conversations, and I hope our voluntary sector partners feel like they can open the door and have those discussions with us. It would be inappropriate for me to make false promises though, because we have to look at that within the constraints of our budgets. Then obviously regarding how we look at our community assets across the borough, I think we're doing more systematic work. You can see from the data where we're really looking at all of the strengths of the types of organisations. We're really lucky to have a very broad array of organisations in the borough, but we note that we do have lots of smaller organisations who can often be quite fragile. And we know from across the country that the middle income organisations also face real challenges around income sources. So we're strengthening how we're working locally in each of our towns, as well as looking across our key priorities to make sure we're looking at that too. I hope our relationships will continue to grow and strengthen in that way. In terms of community spaces, it's one of the areas I think I've had most chats with our voluntary and community sector, and it'll be familiar to many of you around the table. With our partners across the LSP, we've been having looks at all of our community assets and all of our assets and been mapping that, and that's an important piece of work. And we're also having conversations with our colleagues in property to look at that. Lots of our voluntary sector already use a lot of our assets from the council, and that's fantastic. But we also should acknowledge that the borough doesn't have an unlimited amount of space. There's going to be always more demand from the voluntary community sector, particularly for more space, but also types of suitability of space. And I'd love to be able to wave a magic wand, but unfortunately we don't often always have that in our portfolio of properties. So we should also acknowledge how can we be more creative. So for example, in Greenford, alongside colleagues up there, we're looking to work with other spaces to celebrate the breadth of networks and spaces that we can have and invest in those. So we're trialing something called a community living room approach, where we can really look at those kinds of different spaces and open up access as much as possible. So we'll continue to look at that, but there's no easy answers.
Thanks, Carrie. Really comprehensive response. Marie, I'm not sure what you can add, but over to you in case there is something.
Good evening to the committee, and sorry I'm not there in person, but lovely to meet people, even if virtually, this evening. So Marie Snelling, Interim Strategic Director for Strategy and Change. Nothing further to add. I mean, what could you say after that response? So thank you, Chair. I shall, for brevity, keep quiet on that one. Thank you.
Thanks, Marie, and really nice to meet you virtually. Questions from other panel members? Gule.
Just a quick one. Given that respite for carers is often unavailable and is assessed case by case and capped, budget runs out, how will you set the VCSC grants program priorities from 1st of October 2027 to expand fair access to short breaks and respite, reflecting evolving community and carers' needs, and invest in the strengths of local communities with targets for housebound support, especially for unpaid carers, and for emergency cover and crisis pathways for unpaid carers? Thank you.
Carrie, is that one for you? Yeah,
I can cover that one as well. Only Tristan Bryce, who can't be here, is leading on our recommissioning of this area, but I've been working closely on that process. So what's really important is that we look at that total amount of need, and if we're facing higher demands on that, we have to look at that in the round. But it's also important in those conversations that we look at the strengths in our organisations locally, where we have different strengths and where we could look at different approaches to that. So we've started those conversations now. We've got 7 strategic priorities in our VCSE grant, carers being one of those, and we want to have conversations with people like yourselves and the array of different organisations to make sure we look at the different options about what that would look like and what we need to change in order to better meet those needs. So hopefully by starting now or already, we're in a good position to have a really strong case about what's needed, and that is a good recommissioning position from there.
Thanks very much, Carrie. Any further questions from panel members? No? In which case, I say thank you very much, Anna. Thank you, Carrie, and thank you, Marie. Much appreciated. So that brings us to the end of the meeting. However, I just wanted to say, as it is the final panel meeting before the election, it's been a huge privilege to chair the committee, but also I just wanted to place on record my thanks to my vice chair, Councillor Steed, for your support, and in particular Anna Marie, who does all of the heavy lifting behind the scenes and keeps me in check check, but keeps all of you in check as well. So thank you very much, colleagues.
Chair, it falls to me to express the gratitude of all the members of the panel. Excuse my throat. As we come to the end of this council year period, we hope to see everybody around the table sometime in June, I think it would be, I guess. Thanks to yourself as chair and your calm and reassuring manner in which you perform that role. And also I echo the thanks to Anne-Marie, who is formidable to deal with and enormously competent. And huge thanks to her for making the whole show run as smoothly as it does.
Thank you very much, everyone, and I hope you managed to enjoy a bit of the rest of the evening.